Thank you, John. So we've heard an awful lot of really interesting stuff this afternoon about fever and high temperatures. For the last two papers this afternoon, we're going to cool things down a little bit. I normally get that reaction to my little quip. Okay, so many colleagues and friends in the room will know that I've spent most of my career interested in this problem, Raynaud's phenomenon, caused by the inappropriate narrowing of small skin blood vessels on exposure to stimuli, typically cold or emotional stress, which is a very common condition in females affecting the fingers and toes. As you see from this picture, we'll see colour change in these patients, particularly in the Caucasians with naturally pale skin, so we hear patients describing blues and reds. More importantly, it's an unpleasant experience, so the fingers and toes can be numb. There are sensations of paresthesia or pins and needles. Loss of function. We have patients who can't count money or turn their own front door key. Important to all of this is a delayed rewarming. It takes a long time to thaw out when these episodes happen. And it's a very common disorder. As a standalone or primary condition, up to 10% of the general population might suffer from these episodes intermittently in cold climates like the UK today. It's a much rarer condition, secondary to certain other diseases like connective tissue disorders. Is an important sign of those diseases. And there has been an awful lot of literature over the last 40 years, with Francis being a key contributor, in fact, pointing to the fact that if we come up with a simple hospital-based laboratory test which deliberately mildly cools the hands and finds some way to assess rewarming, we can detect which patients are clinically suffering these kind of episodes. And we presented some very, very simplistic data some years ago at the meeting in Krakow, suggesting that if we cool our patient presenting to clinic with Raynaud's phenomenon in water for a minute at 15 degrees Celsius, and simply with thermal imaging measured the mean fingertip temperature after they've been allowed to rewarm those hands for 10 minutes, if we choose a cut-off rewarming temperature of 31 degrees Celsius at the fingertips, we can predict who, as measured against the clinical assessment gold standard by my clinical colleague, we can predict who has Raynaud's phenomenon with an 81% sensitivity and an acceptable 86% specificity. There are probably better ways of evaluating cold challenge response, like looking at gradient rewarmings or various recovery indices. But I think that data just showed that even a simple cut-off, if you wait for 10 minutes, can detect who has this disorder quite reliably. So we know thermal imaging is of value, and it's a very established technique to look at Raynaud's phenomenon with these fixed installation, if you will, desktop thermal cameras. The problem about these devices, like our FLIR A320 on the left, is that they are quite expensive devices. So that limits who can get them into the clinical use. And we wondered, for our little investigation, whether these kind of handheld, rather less expensive portable devices, which are really coming onto the market nowadays for things like building inspection, in any way measure up to the reliability of using a more expensive laboratory device. So we acquired the FLIR E30 device at spring last year. Here are the specifications of the two devices that we now have at the Royal Free Hospital. So the A320 is a 320 by 240 pixel device. The portable E30 device, 160 by 120. The stated accuracy by FLIR, the manufacturer, is in fact plus minus 2 degrees Celsius for both devices. In fact, as we'll go on to see with some quality assurance, we can do far better than that. So the criteria are quite broad, quoted from the manufacturer. Clearly, the E30 is a handheld porter device, whereas the A320 is fixed. But the key difference between these two specifications is the E30 comes in at less than 1/5 of the price of the A320. Under the bonnet, so to speak, these cameras operate very similarly. They're microbolometer uncooled focal plane array images, sensitive in an infrared wave band of 7 to 14 microns. So we put together a little study, and it began with step one, where we sent Rosie Richards, our trainee clinical scientist who's here today, all the way up to John Allen's lab in frosty Newcastle. We were very grateful to John for inviting us up there, and that gave us access to John's excellent facilities for doing quality assurance, because he had the blackbody cavity up there. And Rosie did some simple quality assurance of both cameras, because as we've heard today, we need to understand how these devices are performing before we even consider using them in clinical practice. Step 2 was then to bring both cameras back down south to my lab at the Royal Free Hospital. And in the first couple of weeks of this year, in fact, I made some routine measurements of 15 clinic patients attending our Raynaud's clinics at the Royal Free, but we also captured additional data using the E30 handheld device. Then the final step was to look at that data and evaluate the agreement between the two cameras for the assessment of finger temperature, in order to answer the question, can we use the two devices interchangeably, or are there important differences? Now, those of you who were at the seminar in Vienna at the end of last year will have heard Rosie describe very nicely her quality assurance experiment, so I'm not going to go into that in a lot of detail today because of the time constraints, but I'm just going to run through those in summary. Here's the quality assurance equipment that we had access to up in John's lab. So John has the excellent LAN P80P blackbody calibrator. So this is a device that we can set to a known stable temperature inside the cavity here when we're looking through there. It's a very high emissivity target, greater than 0.995 emissivity. And if we insert into there a platinum resistant thermometer, we can read off and know the temperature of that target with an uncertainty of around 0.1 degrees Celsius. And we also had access to a spatial resolution test object, which is basically an array of heated bars, so that we can judge whether we can resolve certain sizes of object in both thermal cameras, and that was developed by Professor Ring's unit at Glamorgan. And if we look very briefly at what Rosie concluded in these very simple laboratory experiments under considerable time constraints, she had 2 days to do this, so credit to her. Rosie first of all looked at drift of the cameras after switch on. We know that these thermal cameras tend to vary their output reading a little bit in the minutes after they're switched on from cold. And Rosie found that the E30 handheld device ends up fluctuating around the true black body temperature by only about plus minus 0.1 degrees Celsius once we've let it switch on after 45 minutes. Similar figure for the A320 was plus minus 0.2 degrees Celsius, so they're quite similar cameras in that sense, although the A320 actually achieved that stability rather faster after switch on. We also know that thermal cameras, especially the uncooled devices, tend to give a drifting output with varying room temperature. So we took John's lab across an 8 degrees Celsius room temperature range. By the end we were really pretty warm. And we found that if we vary the room temperature by as much as 8 degrees Celsius, the reading we get from the stable black body temperature varied by around 0.4 degrees Celsius across that 8 degrees Celsius temperature range. We think that's pretty good, considering in most controlled temperature labs we're not going to be varying the lab temperature by 8 degrees Celsius, but perhaps by as little as plus minus 1 degree. Rosie also looked at uniformity across the image fields of view, which Graham mentioned earlier, and she found that if we use the E30 to look at the black body target in the 4 different quadrants, the 4 corners of the field of view, we only got a maximum difference of the black body temperature across those 4 quadrants of 0.2 degrees Celsius. Do the same thing for the A320 fixed camera, we get a slightly greater stability of 0.1 degrees Celsius. And that's quite a reassuring figure for both cameras. And we then looked at agreement with the black body source at various source temperatures over a range of 20 to 40 degrees Celsius. In other words, sensible medical skin surface temperature range. And also use that data to create a calibration of each camera against the black body source. Now perhaps the best way to look at agreement between the black body source and the reading of each camera is to use a mean difference plot. If you're a clinician, you'll know these as Bland-Altman plots. So what we're doing here on the x-axis is plotting the mean temperature, or the mean of the camera reading, and the true black body cavity reading. And we're plotting that against the difference between the black body cavity and the temperature that the camera was reading. And we can plot here in the blue line the average difference across all temperature readings, known as the bias, and we can also plot the range of differences either side of the bias, across which we would expect to find 95% of our differences if we added more data points in. Graham's nodding as a sort of fact there. That's good to hear. So if we do this for the A320, we can find we get a small bias, the overall mean difference from true, of only minus 0.08 degrees Celsius. Interestingly though, this camera tends to overread the blackbody at low cavity temperatures, and there's a tendency for the device to underread the cavity at higher temperatures. If we do the equivalent for the E30 device, again on average we get a very small bias of only plus 0.09 degrees Celsius, somewhat wider limits of agreement in this cheaper device. This time though, the tendency of the measurements is in the opposite direction, so the E30 tends to underread the true temperature at low cavity temperatures and overread the cavity at higher temperatures. We also looked at spatial resolution. Here's a thermal image of the test object taken with the more expensive A320 device, and you can see that device is easily able to spatially resolve the differences between these small bars spaced at only 1 millimetre in both the X and Y directions. But if we take the equivalent image with the E30, we have got, because this is a smaller pixel array, somewhat more limited spatial resolution. We're not in some cases able to resolve spaces between these 1 millimetre bars. So in conclusion from the quality assurance, we found that both cameras performed pretty well under quality assurance tests. They had acceptable drift, linearity and uniformity across the field of view, but you do get what you pay for, so the A30 has reduced spatial resolution compared to the A320. And Rosie was also able to do a best fit calibration curve, y equals mx plus c, using the data I've showed from the Bland-Altman diagrams, and that can be applied to correct readings to nearer their true value in clinical practice. So moving on to step 2, I then made some measurement of cold challenge responses using both cameras in our patients referred to the Royal Thermography Lab. And these were 15 consecutive patients who came in January, early this month. 11 of those were female and 4 male, and you can see because patients are coming in a wide variety of clinical contexts, we had a very large age range. 1 or 2 were paediatric, age range 12 to 65 years. Some were cold, some warm. The cold challenge test itself, which we routinely do at the Royal Free, is done at a room temperature of 23 degrees Celsius plus minus a degree. We acclimatise all our patients for a period of 15 minutes in that environment so their temperature is stabilised. We then take a baseline thermal image of the dorsal surface of both hands, and that was done in this case using both cameras. I then glove the hands of the patient and immerse the hands in water at 15 degrees Celsius for 1 minute. It's quite a mild cold challenge really, it wouldn't trouble most of us in here, but remember these are sometimes patients who really suffer the cold. Not enough though to provoke a Raynaud episode, so it's tolerable. The hands are then removed from the water and they're imaged again immediately by starting sequencing on the desktop thermal camera. Then I took an image again with the E30 handheld device, and I took another pair of images 10 minutes after the patients have been allowed to rewarm using both cameras. And in step 3, having collected that clinical data, was to judge its agreement between the E30 and the A320 device for finger temperature assessment. So the images were analysed in the case of both cameras using FLIR Thermocam Researcher 2.9 software. In the case of the A320, those images were captured to the laptop live, so to speak, via an Ethernet connection, because the laptop is controlling the image capture. In the case of the E30, which is portable, we transferred after the event the images that we captured via SD memory card in the laptop. All 8 fingers were included in the analysis. There is some evidence in the literature that thumbs rewarm differently and faster after cold challenge, so we included the 8 fingers. And the regions of interest were circular, drawn at each fingertip. And then we looked at mean fingertip temperature across the 8 fingers, calculated from each of the 3 thermograms. So before cold challenge, immediately afterwards, and 10 minutes after the cold challenge. And we adjusted the values using the calibration curves that Rosie had achieved by doing quality assurance of both cameras. So these were corrected temperature. And this just shows the reasons of interest from one of the E30 images. So we're just trying to find a small reason of interest at the fingertip of each of the 8 fingers. So the outcome result from that image is the mean temperature of all these 8 reasons of interest. I just thought I'd put in here, using uncorrected images, this is what you get straight out of the box from both cameras at all 3 time points from one patient. So you can see, if we compare the A320 to the E30 images, they are really remarkably similar. They tell an absolutely similar and identical clinical story about this patient. We've colorized these images using the same palette, applied the same temperature scales, and they really are very, very similar rewarming sequences, aren't they, for the same patient, same sequence, but using 2 different cameras. So that's encouraging for a start. And if we again use Bland-Altman plots to look at our results, so this is now comparing the E30 and A320. So we've got the mean of the A320 and E30 readings on the x-axis, so we've got the difference between them on the y-axis. And this is first of all looking at agreement between the 2 cameras for mean finger temperature before cold challenge. And you can see here we've got a bias of minus 0.2 degrees Celsius. So the A320 overreads the E30 by about 0.2 degrees Celsius. And we have limits of agreement running from minus 1.4 degrees Celsius to plus 0.9. If we then though look at the agreement we get in the images taken immediately after cold challenge, interestingly here our limits of agreement are somewhat smaller, but the really striking thing is the bias has gone up. Now it seems that the A320 overreads the E30 by around 0.7 degrees Celsius, which is curious, but we think we know why that is, and I'll explain that in a moment. Move to the third measurement made, the rewarming measurement after 10 minutes, and we get something a little more similar to the first Bland-Altman plot. Now the bias is only 0.3 degrees Celsius, somewhat smaller. We think the reason for that is the methodology of how we did this. I've only got 1 pair of hands, unfortunately. Okay? And when we bring patients' hands out of cold water, some of the 15 patients would have been rewarming at that stage very rapidly. And there was a time delay between me pushing go on the laptop and beginning the sequencing with the A320 camera and being able to get round to measure manually using the E30 handheld device. And so we think this is due to the methodology. There is a 0.7 on average degree rise in temperature during that time. Now we also had amongst these 15 patients some really quite interesting clinical cases. This gentleman was referred to us with the symptoms of primary Raynaud's phenomenon. If we call him and watch with both cameras how well he's rewarmed, this is the A320 image, the fixed device, this the portable, we can see that both images tell a similar story, and there is something really rather curious going on here, not really suggestive of primary Raynaud's phenomenon. In fact, there is some thermal amputation going on in 1 or 2 places. It means we don't get rewarming beyond halfway along the fingers, which to us rather suggests small arterial disease, and this patient certainly needs further investigation. But I put these images in to demonstrate that although we clearly have lower resolution with the E30 device, we can still tell that useful clinical information in the lower resolution, less expensive camera. This is the beauty of thermal imaging. A picture speaks 1,000 words. And although radiometric accuracy is important, to be able to see the image and see the overall scenario is also very, very important. So in summary, we found interestingly that, coming back to my somewhat arbitrary cut-off of 31 degrees Celsius, we found the 2 cameras would have agreed about the classification, Raynaud to non-Raynaud, of all 15 patients based on that cut-off. And that was true for both the corrected data, using Rosie's calibration curves, but also even the non-corrected data, using the cameras out of the box and not considering calibration. That, of course, though, is device-specific. If you're using another pair of cameras, it may not be true you can use them out of the box. That's why you need quality assurance before you even start. But we were quite fortunate here that these cameras agreed acceptably well anyway for this kind of application. The agreement between the two devices in clinical practice isn't just, as Helen mentioned this morning, to do with how well the devices agree in a lab or against the quality standard. It also depends on the protocol. And we saw a big bias occurring simply because of the way I make the measurements. There was a time delay between measurement A and measurement B. For example, we found a smaller bias from readings recorded before cold challenge. This is a steady state situation. Nothing is changing, and it doesn't matter you make one measurement after another. And that's probably similarly true 10 minutes after cold challenge when patients would be warmed by then. The largest limit of agreement we observed in any of the three Bland-Altman plots were plus minus 1.2 degrees Celsius. In other words, that's the range either side of the bias that we would expect 95% of data points to lie within, which I think for Raynaud's work is acceptable. Our image quality was lower for the E30 than the A320, but the limited spatial resolution, as you saw, didn't prevent us seeing important clinical details in the thermograms. So in conclusion, we find that portable thermography could offer an inexpensive alternative to fixed installation cameras for the application of Raynaud's phenomenon assessment. We saw adequate agreement between the E30 and the more expensive A320 device. Of course, you do get what you pay for, so if you buy a portable inexpensive device, you have limited software functionality, you can't sequence driven by a computer, you've got limited connectivity, it has to go across to a computer on an SD card. But the lower spatial resolution doesn't seem to be a limitation for Raynaud's phenomenon when we're working on the hand. That, I believe, is it. Thank you very much for your attention.